Well, thank you so much. That's probably one of the more a very enthusiastic welcome for me. And I'm so pleased to be here and to talk to you about important things to us in terms of some of our activities related to advancing science in myeloma, and to update you on what has been going on in research and what our options are for treatment. So it's impossible to talk about all of myeloma in about 45 minutes, so we thought we'd focus on a little bit of a primer as to what clinical trials are and why it's important to try to participate and what we can offer from that perspective, and then to give you an update of some of the things that were presented at our American Society of Hematology meeting in December of this year, and so kind of heralding what's new and what's hot in the last year or so. So I apologize, I'll have to go back and forth to just advance the slides here. Those are just my disclosures. So as an outline, I'll give you an overview of clinical research trials, why one should consider participating in them compared to just standard of care treatments, and then give you some updates from ASH. So we'll talk about sort of 4 areas where there were studies presented which advanced what we know about these areas. So we'll talk about the number of transplants that one would consider having for newly diagnosed eligible patients, some new data on initial therapy for patients who are not eligible for transplant. We'll talk about treatment for relapsed and refractory disease and a little bit about new drugs on the horizon. So, and the webinar that Dr. Trudell and Dr. Reese are putting on Monday would talk about this in much more detail, with the hot area being immunotherapy, and that's sort of the buzzword in myeloma. And also a little bit on some new data on supportive care, some extra antibiotics we might consider giving along with our treatments. So what are clinical trials? So clinical trials, for those that have not been involved in them, and as a reminder for those that have been, are research studies that involve people. They're the final step in a long preclinical process that involves developing new treatments. They're responsible for many of the treatments we have available today. And in cancer, clinical trials are designed to answer questions about new ways to do things like prevent cancer, find and diagnose cancer, treat it, but as well as manage symptoms of cancer or side effects from treatment. The process of a drug, for example, going from an idea to being available for a patient is really quite lengthy. And that is designed to really prove that such a drug is safe and efficacious, and actually has added value to the care of a patient. So if someone has an idea in sort of the discovery phase, there's some basic research that occurs, and that's usually in the lab, where a drug is developed, a compound is formed, and then it's tested in things like mice, in cell lines, et cetera. And then if it looks promising, it moves through into clinical trials, and there's different phases of trials depending how early or how developed that drug is, and I'll show you another slide on that. And then if it does go through to something, to a large trial like a phase 2 or 3 trial, and it's shown to be safe and efficacious, then there's a whole process for regulatory approval. So then it's going to the governments to say this is a useful drug, and looking at getting it approved and looking at funding for it. And that's, so it's a long process to then reaching patient care as a standard of care for everybody to access. So a little bit more about what these different trials are, because at all times, for example, at Princess Margaret, we have a number of trials available for different lines of therapy, and the trials can be at different phases of development, and that is important to remember when one is looking at a study and at options. So first of all, out of all the out of 100 drugs that enter phase 1, which is the first phase of testing a drug in humans, only about 16 ever make it to, for example, FDA approval. So a lot of drugs, although tested, are not shown to be efficacious, or maybe they're unsafe, or side effects develop where it's felt that they should not be carried forward. So phase 1 trial really is where its main goal really is to check for safety. And it's usually tested in somewhere between 20 to 100 patients. It says here volunteers, but really in our cases we are looking at usually cancer patients who have exhausted a lot of other lines of therapy. And because with these drugs, we don't really know yet necessarily a lot about the safety or if they'll even work. But there may be a signal again from the lab that it's something that's worthwhile testing. So that's the first stage of testing in humans. If it's shown that the drugs are safe and there's a signal that they might work, then they go to a phase 2 trial, which is it is checking for efficacy, and usually those are numbers that we usually these are gotten from diseases that have many more patients than us, like breast cancer or colon cancer or heart disease, for example. So our numbers usually are much smaller that we are working with because of the number of patients we have with these diseases, but a few more patients than you'd see in phase 1. And that's asking the question, how well does the drug work? Do we see a response when we test it in 50 people? Are we seeing at least, maybe a third of the patients responding is usually an amount that people would look for to then consider taking it forward. And if it does look like there's some efficacy, then it might go to a phase 3 trial where it's comparing this new drug to what might be a standard treatment already available to say, is it better or is it as good as other things we have? Sometimes some drugs do go into what's called phase 4 trials, so they've already been approved and they're out there for use, but there might be a sort of a surveillance study where it's trying to now gather data on real life patients, because a lot of our trials have very shorter follow-up. You might only have 2 or 3 years of follow-up, and you want to know what happens when someone's been on it for 10 years, and when lots of people have been on the drugs for 10 years, are there side effects we didn't know about? So those sometimes are captured in phase 4 trials. There are also different types of trials in terms of who runs them, and this sometimes is relevant in terms of even the funding that's available, how many people we can put on. So we like what's called investigator-initiated trials. Those are trials usually developed by people like myself or my colleagues at Princess Margaret. So doctors doing this or investigators doing this, where they want to test a question. Usually there's single or smaller number of centers. May take longer to complete because again, we're usually working with less amount of money or less amount of power than a big pharmaceutical company would, and often the sample sizes are smaller. There are what's called cooperative group trials, so where in most countries and in Europe, a bunch of countries together have kind of run groups that try to run trials across a whole country. So in Canada, this is called the CCTG, or the Canadian Clinical Trials Group. A part of that, and the same idea as MCRN, which is an offshoot of Myeloma Canada as a research network, and we're running trials through that. And the idea is to try to connect all the centers across the country and have these trials available to everybody. And then in the US, there's some cooperative groups as well, and in Europe, EORTC, for example. And then there's the large pharmaceutical company-driven studies, which is what a lot of drug trials are these days. So the advantage of that is that often they're larger trials, they go quite quickly, it's to move information forward. But often we don't necessarily have as much control over how this trial gets designed. It gets designed by the company with with expert input. But if there's a certain combination of drugs they want to put together, that's the combination that it is. Why are phase 3 large trials important? And if you have 50 or 100 patients on a trial without a comparator and you show a response rate, why is that often necessarily not good enough, for example, for a drug to get approved or to be funded, is that we know that the patients that can go into a trial can be a certain population. Every center could have different types of patients that they look after. And also, if you only put 10 patients on a trial, even if you're randomizing them, out of chance, it might be that only 3 out of the 10 get the treatment and 7 out of the 10 get the control. So it might not be enough patients to really, first of all, you're not getting an equal distribution of patients in each arm, and there's not enough patients to really compare the differences. So we need large trials to make sure that we have the same kind of patients going into each arm so that we can compare to say one drug is better or worse than another, and to have enough people get the drug to be able to understand both the efficacy and the side effects.
Excuse me?
Yeah.
What are the ethics of not giving the drug to some patients, or is there an alternate treatment they're getting at the same time? Because
Right.
my wife here was offered, that's back in the old days when they had thalidomide and that.
Right.
Initially, Dr. Trudell suggested she go in the trial, and we said, well, we didn't want her not to be on anything.
Right.
And so they just put her on without her being, she was part of the trial without her really being part of the trial.
Right.
What happens to patients that they're in full disease here, and you're not giving them the treatment in the trial?
So that's an excellent question. So the question is, what are the ethics of offering a trial, if I can understand correctly, where there might be a placebo as the comparator? So I would say that these days in cancer and in the trials we're offering, it's very rare to have a complete placebo as the comparator arm if we're talking about a disease management, so looking at full treatment. The only time we still have placebo is if there's truly clinical equipoise as to whether a drug works or not. Most of the time in myeloma, for example, that would be for example, some of the maintenance trials might still have placebo as a control, because we don't necessarily, so for the non-transplant eligible patients, although the data's now suggesting that it makes sense that maintenance works, we haven't had big trials to prove that maintenance is better than just being observed. So in those cases, ethically, it's felt that comparing to a placebo is reasonable. So the only time trials still offer just placebo, again, is if there's equipoise about the question. Otherwise, there's always an active comparator, usually the standard of what otherwise you would have gotten if you weren't going on the trial. So just as an example, and I'll talk about this trial a little bit further down when we talk about the ASH update, but this would be what a design of a randomized control trial would be. So there's often an experimental arm and a control arm. So the top arm is the experimental arm. So this trial had 2 randomizations, and so at the beginning of the trial, you're randomly placed into either group. And often key endpoints are things like progression-free survival. What's the chance that at 2 years or 3 years you haven't progressed and one hasn't died? The response rates and quality of life has become an important endpoint in most clinical trials being done these days. So what are the pros of participating in a clinical trial? Usually, cancer care is always high quality, but often on clinical trials, patients have access to a clinical trial nurse, and generally probably sort of a feeling of VIP in terms of the access to speaking to someone and connection from that perspective. One may have access to novel therapies that are not available to the public. The new treatment may have less side effects than the standard therapy. It does help others by furthering science, especially if there's tissue and cells that we can collect and bank to study. Often parking can be covered or subsidized as part of the clinical trials, and it may feel like an active role in a decision that affects a patient's life. What could be some of the disadvantages? There could be worse or unexpected side effects. Sometimes we don't know all the side effects of a drug, that's why we're still testing it. The new treatment may not work. Most often being on a trial means more visits and tests. If it is a randomized trial and testing two different treatments, you may not get the experimental agent or the intervention. And this is less of an issue, but occasionally the new treatment, if the treatment is only for a defined period of time, the new treatment may not be available once the trial ends. But usually most trials these days offer the drug if it's working for as long as it's working once a patient is on the trial. So how do you get on a trial if that's an interest? Ask your myeloma team. If you're in our center where we have clinical trials, ask about it. If you're a different center, we have a very well-organized network across the city, I would say, in terms of our colleagues at other centers know to call us if there's a question of a trial being a useful option. It is important to remember, because there are trials, they have very picky or can be picky eligibility criteria. So even if a trial could be an option, there might still not be a chance you can't get on because of that. Look at the get an overview of the study from your doctor or the coordinator, and if a consent form is given about the trial, always important to bring a friend or family and take time to read at home and ask questions. So questions to ask. I'll do it this way because of all the clicking. What are the details of the treatment? Is it oral? Is it injections? How often do you need to come? How long duration of the treatment? Will you always get the treatment, or is it randomized? Will you know what treatment will you get, or is it blinded? It's quite rare for us to have blinded trials, but we do sometimes, especially if it's with pills. So that means you don't know if you're getting you could get a sugar pill or the active pill. What extra tests are needed? People generally hate bone marrows, but some of our trials require repeat bone marrows and some do not. CAT scans, x-rays, blood tests for drug levels. What are common and serious side effects that might be known, and are there extra costs related to the trial? Again, to reiterate that this is a long process, so that's why sometimes it takes a long time for drugs from being tested to get to the funded phase, because from a protocol being approved, there's many steps that need to happen till a trial is completed, and the drug could be looked at becoming standard of care if it's efficacious. So I'll move on, unless if there's other questions about that, but we'll have lots of questions time at the end, I think. So mostly, I just have a slide about some of the drugs that we do have available, and then I'll move on to what's new. So now it feels a little old, but funnily enough, we're still waiting for funding approval for a couple of the drugs that are almost there. So there are about 4 new drugs for relapsed myeloma approved by Health Canada in 2016, on top of the ones that are standard of care for us, and we have. So we have bortezomib, lenalidomide, and pomalidomide, and the 4 drugs on the right, carfilzomib, ixazomib, alatuzumab, and daratumumab, were found to be active drugs in myeloma. A couple of them are likely not going forward for funding, so we can, certainly if you have questions around how about that process at the end, we can talk about it, but the process of how drugs get approved and considered to be worth funding by provinces is a complicated one. But I think where carfilzomib is, we expect a funding announcement anytime, and so I think that's going to be available to Ontario patients, both in combination with Revlimid and on its own shortly, and daratumumab is working its way through as well. So I'll move on to talk about what's new in myeloma, some of the data that we've had presented at ASH, and it is important to, again, remember all the steps between trials being read out and getting to funding, but at the same time, we work very hard at Princess Margaret and in the city to find ways to get these drugs to our patients before they're funded, whether it's through clinical trials or working hard with the companies to get compassionate access to these drugs. So this data is very relevant if we think there's something new and interesting that we should be offering even before funding comes. We work on trying to get that access. So what are the, I just wanted to present a short overview of what our algorithms in a very simple way are right now for treatment, particularly for first line for patients. So at Princess Margaret, if a patient is transplant ineligible with a sort of, I'm not going to say loose-ish, but we have a cutoff of about 70, although that other things go into that, including fitness and from an eligibility perspective. So if patients are over that age or have poor fitness level, or we don't think that the toxicity of an autologous stem cell transplant would be too high, the current standard of therapy is to give oral Revlimid and dexamethasone, or a combination with melphalan and prednisone. So the other regimens we've had are in combination with Velcade, which has been our standard for many years. Melphalan with prednisone and thalidomide is still an approved regimen that's out there as an option, although it's not something we've used really much at all anymore because of the toxicity of thalidomide. And for transplant eligible patients, so about 70 or less with good fitness level, we give induction therapy with a Velcade-based regimen, so Cyborg-D, then there's a stem cell collection, stem cell transplant 1 or 2, depending on high-risk features, and then maintenance lenalidomide is our standard approach to first-line treatment. And then if there's a relapse or refractory, there's many pathways that patients can go down depending on trials available, age, what treatments they've had before, et cetera. So I'll talk now first about some data in frontline for transplant eligible patients and the question of should everybody have 2 transplants or is 1 good enough? So we've known, so the concepts of tandem transplantation is that patients have 1 stem cell transplant. If it goes well, 3 months later they have a second one. So with the idea of more chemotherapy or more treatment might be better than less. And we know from a trial, this IFM trial, that has shown that doing 2 transplants over 1 might be beneficial. But this was before we had all the novel agents. It was in an era of mostly having chemotherapy with dexamethasone, and there was no maintenance or consolidation at the time. And the advantage was about 5 months. So overall, we have not felt that offering this in the modern era, offering it to everybody, this data doesn't quite apply anymore. But we know that for high-risk patients, so patients who have high-risk cytogenetic changes, that might be an option. And that is, I think I have another one, but it is our policy to offer tandem transplantations for patients with high-risk disease. A trial last year at ASH looked at randomizing 3 different randomizations with testing that question. So saying, so people had 1 transplant, so everybody had 1 transplant, but the induction therapy was actually a much more aggressive regimen than we use here. It's something that's used more in the US, which combines Velcade with Revlimid. So it's a regimen called RVD. So when the patients had that induction and they were randomized to having a transplant and then just having maintenance afterwards, which is what we would normally do, having some more chemotherapy, RVD, and then maintenance, or having a second transplant and having maintenance, there was really no difference between the 3 strategies as to how people did. So it was felt that having a second transplant or even having more chemotherapy after transplant didn't really make a difference. So our approach as to how we're doing is reasonable. So just to conclude that, there was no difference between single and tandem transplant in this era of novel agents. This year, a study was reported, and which looked at an induction that, again, we use more commonly, or it's kind of mirrors what we do in Canada, which is VCD, which is the same as Cyborg-D, just given a little bit in a different way, so cyclophosphamide, Velcade, and dexamethasone. And then patients were randomized to either just having more chemotherapy and not having a transplant, or having a transplant, and that could be 1 or 2 transplants. And it's a little bit confusing, but I'll just say that, so the centers that went into this trial, some centers had a policy of always just doing 1 transplant, and some centers have a policy of always doing 2 transplants. So in Europe, there are some places like in Germany where they do tandem transplants for everybody. So in this study, for the centers where they're okay with doing tandems, patients were randomized between having just 1 or 2, or just having none at all. So it's none, 1 or 2. And then there was a second randomization where there was more chemotherapy versus not, and then some maintenance. So lots of things going on in the study. But what we're looking at is this randomization between having 1 or 2 transplants. So again, people had the equivalent of Cyborg-D, and then they were randomized to having just 1 transplant versus 2, and then some other things happen afterwards. So what we're looking at is, did a second transplant help? And what this is trying to show is that, so the bar on the left is after 1 transplant, the type of responses patients had. So we really quite care about deep responses, so what's VGPR and CR, so that's the gray and the yellow, and green is a stringent CR, so where really you can't pick out any kind of myeloma cells. So we can see that the amount of yellow and green increased after the second transplant compared to the first transplant, saying that there were deeper responses that were achieved with the second transplant rather than just having 1. And half of the patients were able to achieve a CR or better. Yes?
Is there a decision about doing 1 or 2 based on how many stem cells are harvested? Like, is there a difference when you're giving the stem cell transplant if you've only got, say, 10 million rather than 20 million, like whatever the numbers are, right? Is that part of the decision?
So that's a very good question. So the question was whether it affects the decision how many stem cells are harvested if you have enough for 2 versus 1. I would say in our practice, for most patients, we always collect for 2 stem cell transplants, and a lot of centers do that. So even though if we might not do a tandem, we sometimes do a salvage transplant if patients get enough out of a first. And for most people, we're able to get it. So for the amount, we know we need a certain amount. So you need in myeloma, about 2 million cells per transplant, so we need to get 4 per patient, and in most patients we're able to do that. It's very rare not to be able to achieve that. So the study hasn't been published, so we don't have the details of were there any patients that didn't have a tandem because they weren't able to collect enough stem cells, but I would suspect that number is quite low. So it's not usually a big, we're able with strategies we have to get to that number in most people. Yes.
I keep asking this question, how long can you store frozen stem cells?
It's a good question. So the question is, how long can you store frozen stem cells? We probably have some stem cells in our freezer for even from 10 to 15 years ago. So you definitely for years and years. And I don't think we have good data that says they're at some point go bad or anything like that. So we have had patients who had 1 stem cell transplant, did really well, and had, let's say, an 8-year remission, and then have progressed, and then they've had a second transplant. If they're still eligible, then we can use the stem cells that were collected 10 years ago.
So far, my wife is 14 going on 15 months since the transplant. So I guess you can see why we're concerned about the storage life of her.
That's long, but they're probably still okay.
As Andrew nicely said in response, he says you're on the far side of the bell curve. Whether that's a compliment or...
Well, hopefully you never need them again, so, right. And the truth is that in most people, although we store them, especially if people haven't had lots of treatment in between, we're also probably have pretty good success at recollecting. So if one needs to recollect, it's not that difficult. It's more difficult when people have had lots and lots of therapy because that affects your bone marrow and the ability to reproduce them. But even if we thought they had gone bad, probably we could recollect. So what were the results of this randomization in terms of the endpoints we care about, which are progression-free survival and overall survival, so how long people live and how long they live without having relapsed. And there seemed to be a significant difference in both with having 2 transplants versus 1. So people who had 2 transplants actually lived longer than those that had 1.
But the previous trial you showed already there was no much difference. Okay, so this compared to the previous one?
That's right, exactly. So there's been lots of discussion and controversy about this. So they essentially show different results. And so why might that be? So the first trial I showed you was done in the US versus this was done mostly in Europe. And as I showed, the induction treatment was different. So the US patients had RVD and these patients had CyBOR-D, so some would say more intensive induction. There's been, this pendulum has swung and people have very different opinions about, do you need to have a very deep response before transplant? So what matters more, the induction therapy, the transplant, both, the maintenance afterwards, and we're gathering more information from that perspective. But some of the hypothesis has been that in the first trial, maybe the induction is because it was better, got people into deeper responses, so you didn't need to do 2 transplants, 1 is enough. Whereas maybe if you only do CyBOR-D, then the second transplant adds more from that perspective. Also in this trial, some of the patients who are supposed to have tandem transplants didn't for different reasons, because again, it's per center, so it happens to us a lot. Patients, we plan for 2 transplants, and patients only have 1 and have such a tough time that they don't want to do it again, or we don't think it's safe to do it again, so then you don't. But the way trials usually get analyzed is as per something called intention to treat analysis. You analyze people as to what the intent was to treat from the beginning, not necessarily what happened afterwards. So there were some differences into how the trials got done from that perspective. Getting lots of questions. Yeah.
Have you ever looked at all that data and categorized it in terms of what stage they were first diagnosed at? Stage 1, stage 2, stage 3, and stage 4?
So excellent. So the question is, were patients categorized by or analyzed by stage? I did not plant the question, but so this is to show there's about an 8% difference in survival and progression-free survival. But yes, definitely in a lot of these trials, they do get analyzed by the different stages. So now we use the revised ISS, which is 2 blood tests, beta-2 microglobulin and albumin, and then adding cytogenetic data. And in this study, when they looked at particularly the high-risk patients, that difference seemed to be there and probably was driving most of the difference. We, again, don't have the manuscript for this, the full paper, so we can just go what's been presented in a short abstract and in the information. Usually when a paper comes out, it gives us much more information about kind of how different people in different groups did. But it seems that difference between the two is particularly relevant in the high-risk cytogenetics and the higher stages. So, and certainly for discussion in our group, we usually meet around this time, probably next week, where we discuss kind of what newer data and if we need to change our treatment policies. We already do tandem transplants for the high-risk patients, so for these groups of patients, and probably feel that those are the patients that are deriving the most benefit from the tandem transplant, and that not everybody needs to get them. But in the paper, we'll be able to hear, or when we get more information about the lower stage patients, how they did with the tandem versus the single. Moving on to just one other quick update on a frontline treatment, which is lenalidomide maintenance. So we've known that lenalidomide maintenance after transplant improves progression-free survival, so keeps the disease away for longer. And that difference, there's been a couple different trials. This most recent one shows almost a 20-month difference between having maintenance until progression versus not. And but at ASH, they also updated how people did if they had high-risk cytogenetics. So we've believed that lenalidomide is not as active of an agent in patients who have translocation 414, which is a high-risk cytogenetic change, or deletion 17p. And these patients generally do worse with all the treatments we have, but it looks like even in these patients, lenalidomide maintenance, so when we look at curves, if they separate like that, it indicates that the drug is better than observation. So at least we have some reassurance, because that's the only maintenance we have readily accessible right now in Ontario, and it does seem to help everybody. So a few take-home messages. Do we need tandem transplants for everybody or anyone at all? Again, the data is a bit different between a couple of different trials. I think overall we feel that most of the benefit may be in the patients with high-risk features, which is what we're doing already, and likely what we will continue to do. Maintenance therapy consistently improves PFS, including for patients with high-risk cytogenetic features. Yes?
How would you know that taking a high risk for the myeloma, the high risk factor,
how do we determine that? So the question is, how do we know that someone is high risk, has high risk features on their myeloma? So I apologize. Again, don't have enough time to go through. That's something definitely. That's an important feature to understand. We determined that from a couple of blood tests and testing of the bone marrow myeloma cells. And it's very standard across the city to test everybody's bone marrow when they have it at diagnosis for the genetic changes that we know are high risk in terms of the myeloma not responding to therapies as well as we would expect from that perspective. So that's been a well-established concept and test, and we do that across the city. So that's something your one's doctor would order when they do the bone marrow test. Does that answer the question? How about for the transplant ineligible patients? Can we do better? So there are some well-established frontline regimens in transplant ineligible patients. We now have Revlimid and dexamethasone continuously under progression as a standard, and that's based on this trial that compared it to just giving it for 18 months versus melphalan, and thalidomide. And in the experimental arm, so what you can see are the response rates. The progression, what I've put there is just the progression-free survival. So I mean, how long do you on average expect to get from this regimen before the myeloma might come back? So that was about 25 months, which was higher than what the other two arms were, and there was a survival benefit. So people lived longer with this regimen versus the comparator. The standard that we've had of VMP that was established when comparing a long time ago to just melphalan and prednisone, which had been standard of care for 30 years, and the progression-free survival, so the remission length was on average 18 months, so you can see a little bit less than continuous Revlimid and dexamethasone, and there was a survival benefit when adding Velcade to MP. There have been a couple of other studies adding thalidomide to VMP, and the progression-free survival was better, but there was no survival benefit. And people have also compared the newer drug carfilzomib added to melphalan and prednisone to Velcade. Melphalan and prednisone are standard. This has only been reported in an in abstract form, but preliminarily the PFS is about 22 months, but there was actually no difference between the two arms and not really any survival benefit. In this trial, we usually give VMP, or the way we have it funded is for 9 months. That was the original VISTA regimen, but in this last trial, patients stayed on treatment until progression, so it was longer amount of treatment. That might be why that PFS is a little bit longer. So the drug that's everywhere these days, and you may have heard lots and lots about, is a drug called daratumumab, which is a drug that targets, so the myeloma cells have different proteins on their surface that play different roles, and there's ways to make antibodies that attach to that protein and cause cell death. So it activates all kinds of pathways where the cells then die because of these antibodies. So daratumumab attacks a target called CD38, which is a target that's on myeloma cells, and has been proven to be an effective drug even as a single agent for patients. So this trial looked at VMP, which is the regimen I've been mentioning has been one of our standards for 9 cycles, versus adding daratumumab to VMP for those 9 cycles, and then patients stayed on daratumumab afterwards until progression. It was a pretty large trial of about 700 patients, and the primary endpoint was progression-free survival. And it has this, I don't think it's that catchy of a name, but L Sion, I guess. And I'll just do my... So we can see that the patients who had daratumumab added to their VMP had their disease stay in remission for considerably longer than if they just had VMP alone. So at 1.5 years, about 3/4 of the patients were still in remission versus only about half of the patients that had VMP. So that's, I think, a meaningful improvement in outcomes with this treatment. Now, we always look at how long have patients been followed up for already, and that's only about 16 months, which is really quite short for any trials. It's only a little bit over a year. So a number of patients are probably haven't even reached the 18 months. There's statistically ways how one compares this. But we do need longer follow-up to get a better sense of what the outcomes would be, but this certainly looks promising. And as well with one of the concepts in myeloma recently has been that we like to see very deep responses. We want to see that we can't even pick out the myeloma cells anymore, even in the bone marrow, and something called minimal MRD, or minimally residual disease. And that's something you test in the bone marrow where it tries to pick up even very, very few cells left there. And if that's negative, that's believed to be better. And with adding daratumumab to this treatment, it seemed like we were able to achieve these much higher responses. So that's just to add this regimen to the chart we were looking at. So very promising. The challenge is, for those that have had first-line treatment, is that both Velcade, so Velcade is a subcutaneous injection, and daratumumab is an intravenous medication. So the disadvantages compared to what is now our standard Revlimid and dexamethasone, which is an oral regimen, so people take the pills and they can take them at home, is that this regimen is a in-hospital coming to chemotherapy daycare type regimen. So would that be acceptable for patients compared to the oral regimen? And we don't have a trial that's comparing the two yet, or there might never be of RD versus the DaraVMP. So it might have to be a decision kind of comparing the numbers across, which comes with its own issues, and a decision about convenience for the individual patient. So just to take home message there, that RD and VMP are our current standards. This new combination of DaraVMP can be considered a new standard. We, of course, don't yet have funding for this, but I think this will likely move forward as an option. It might be something that we see in the next 1 to 2 years as an option, but we won't know how it truly compares in terms of efficacy to oral Revlimid and dexamethasone. And again, I think it'll have to be a discussion individually about that. And as a group, we'll probably have some policies as to what we think is better. So I'll move on now from first-line treatment to talk about relapsed refractory myeloma, which is a much more open field as to what the options are. And I just have a few points here that have been presented before as to what factors to consider when choosing treatment. And of course, it would be a discussion with one individual physician. But we now have all kinds of different drugs, but some are oral and some are injections. So there's there's different convenience factors there, different toxicities. How they are cleared from the body, kidneys, liver, so if there's some impairment of that might affect what the options are, and what the funding are. Some drugs are not available, and some people have quite good insurance plans that will cover some of these drugs, some do not, so we often struggle with trying to give the same options to everybody. Patient characteristics, if there's other health issues, geographic proximity to the hospital and patient mobility is often a very important issue. If we're talking about oral pills versus injections, for example, age, patient preference, and there may be some disease characteristics as to where we think some of the drugs are better than others. Presently, if I can just simplify it into kind of 3 categories as to what the options are, if someone has had usually at least a couple of years from their first transplant and they're still eligible from an age and fitness perspective, there is an option to do that again, and that we consider. And there are clinical trials, which are always a good option, I think, at any line of treatment when we're talking about initiating a new treatment. And there are for the bulk of patients, we're looking at combinations using approved agents such as Velcade with dex, lenalidomide with dex, and the cousin of lenalidomide, which is pomalidomide with steroids. The first 2 combinations with things added to them usually are in the less heavily treated patients, and the combinations with pomalidomide often in the more heavily treated patients. So I'll just show you a few slides about some of the combinations that have been tested in the relapse setting. And so there are kind of 4 key trials for less heavily treated patients adding to Revlimid and dexamethasone as a backbone. So we've had a study that added carfilzomib, which is the cousin of Velcade, to Revlimid and dexamethasone, and showed a very promising progression-free survival, so meaning on average, how long the myeloma stays in remission, of about 26 months. This is a different kind of antibody called elotuzumab. When added to RD, gave about 19 months of PFS. Ixazomib is the oral version of Velcade, and that when added to Revlimid and dexamethasone is about 20 months. And the very promising combination of adding daratumumab, which, as we talked about, is a very exciting agent right now, to Revlimid and dexamethasone. And the median PFS, which is when 50%, looking at how long it took for half the patients to progress, has not yet been reached. So I think most of us feel the most exciting 2 combinations are really the Dara-RD and carfilzomib RD. Which of the 2 is better is really difficult to tell because they're not direct comparisons, although probably most feel that the Dara-RD is a little bit more active than carfilzomib. So the question is, what is Ninlero? Ninlero is ixazomib. So the 3rd one on the list. Exactly. So it's the oral version of bortezomib or Velcade. So the question is, what's the difference? What does dormant mean, and how does that compare to the word remission? I would say those are the same terms. The dormant, I guess, would be a different way of explaining remission. So we know with myeloma, it's not a curable disease. So we know there's not really any treatment where we can get rid of it and think that it would never come back, although there are patients who are many years out where it hasn't. So maybe one thinks that there are a few of that concept is there. So then we give treatments to do exactly that, to put the myeloma to sleep or to get rid of it as much as possible. So remission really means that we've gotten rid of it, and to some extent there's partial remission where we've gotten rid of some of it, and complete remission where we've gotten rid of most of it or all of it that we can tell, but we know that there's probably a few cells hiding out there that eventually would come back. And I think Dormant would apply to that same concept, like that same idea. So the question is around whether dormant or remission is something we can consider with myeloma. I think we use those words quite commonly. I'm not sure, I hope I'm understanding what you've been told before, but definitely we would say we can't cure it, but remission means that we've gotten rid of some of it to a certain extent. And I think dormant applies to that concept as well. What we cannot say is that it, as you said, that there's probably a little bit there somewhere that, depending on different features, we would think if one lived long enough, it would come back for most patients. That would be correct. So the question is it a good assumption to say that 3 drug combinations are better than 2 drug combinations? I think in most lines of therapy for myeloma, we feel that 3 drug combinations are better. What those 3 drugs are is a variety of things. So if you think of what I showed you in terms of first-line therapy of CyBorD versus RVD, cyclophosphamide, which is the drug in that combination, is a 3rd drug. It's just not a novel agent. So we do use 3 drug combination in most lines of therapy now. I think in the relapse setting, where our standard really has been for 2nd-line treatment, Revlimid and dexamethasone for most patients, which is a 2 drug combination. For a long time, from this data, it's been clearly shown that 3 drugs are better than just the 2. So adding something to RevDex is better than not. There will still be a discussion, though, with patients as to what the goals of care are, because pretty much all these drugs, except for ixazomib, which is an oral drug, all of these drugs so daratumumab and carfilzomib are intravenous drugs. And carfilzomib, as of now, is a twice-a-week drug, 3 out of 4 weeks. So it's a lot of burden on a patient to be coming back and forth for that treatment for some improvement in keeping the disease in remission. So discussion again will go, Revlimid and dexamethasone is still a very active drug, and we have an active combination. And we have patients who have been on that combination for years in remission. So depending on age, mobility, proximity to the cancer center, things like that, those factors will still come into a discussion to say, you might get an extra 6 months of remission out of this combination, but is that worth it for the convenience factor? But if we look at the actual efficacy numbers, I would feel quite comfortable saying that the carfilzomib and dara combinations to RD are better regimens in terms of disease control.
Is there a likelihood of more side effects with 3 drugs versus 2?
So the question is, are there more likelihood of more side effects with the 3 drugs? And for most, I shouldn't say for most people, so the answer is yes. Of course, if you add an extra drug, they will have more side effects. So that would come into consideration as well, whether that's something that's worthwhile. So daratumumab is a very well-tolerated drug. The main side effect is infusion reaction. So when you give it for the first couple of times, people can have quite a significant reaction to it. So that's why we give it very slowly in hospital. But other than that, it doesn't add a lot of side effects to Revlimid and dexamethasone, for example. Good question. So the question is around how sensitive are detection limits for myeloma. I would say for blood monoclonal protein detection, we have quite sensitive assays. So sometimes it does get to the point where they can't quantify it anymore, but they're still able to tell us there usually comes in the wording of a trivial spike. So, and they can still identify that it's the abnormal protein, just in a very small amount, versus not detecting it at all. So, but does that mean that there still aren't some myeloma cells in the bone marrow? No. So the next step is exactly
It means that according to the detection limit,
right.
you're in remission or maybe a complete remission, but not really. It's if you had a more accurate analysis, you would find that, like, say, if it was 1, it might be 0.1.
Right.
But they just don't use that because it's maybe impractical.
So again, in the blood, we're pretty good at not detecting it at all, but the definition of complete remission is actually based on the bone marrow. So just based on blood, we cannot tell that someone is a complete remission. You have to do a bone marrow test to look for the abnormal cancer cells and say that they're not there to call that a complete remission. And what minimally residual disease tests is there's special tests to detect even a few abnormal plasma cells. So if we do all those tests and we can't detect anything at all, does that mean cure? That's what people are maybe talking about now, because some of these patients, a few years out are doing very, very well. So it'll be interesting to see that data follow out to say if you went into MRD negativity after a stem cell transplant, for example, and 15 years later or 20 years later nothing's come back, could we say that those people are cured? It's possible. So the question is around allogeneic stem cell transplant as a cure. It's I'll probably leave that topic a little bit aside for it. It's occasionally people do have allogeneic stem cell transplants for myeloma. We're not quite sure that it works, but. So it sounds like there's 2 questions. The first question was around, can you have a stem cell transplant if your platelets are greatly decreased? And as a higher level answer, I'll say yes, absolutely. We don't have any, especially if it's related to treatment. So one of the side effects of induction treatment like the bortezomib is that patients' platelets drop with that. And that's an expected side effect. So we have ways of managing that. Now there might be individual factors as to why it might be more concerning or not, or looking into why the low platelets, if there's a reason that they're a surprise, but it's definitely not a exclusion from that perspective. And I'm not sure I understood the second question fully. What if maybe? So it sounds like your question is around why do blood counts in general fluctuate. So our bodies vary. You're right. There are a number of different factors that affect the number of things like platelets and white cells that we see in the blood. Platelets are I'm going to say an inflammatory marker. So if someone has an infection, for example, their platelets can go up quite a bit. Even those without a myeloma or a cancer. So because of that, they can fluctuate on a day-to-day basis, just in terms of how much the bone marrow puts out based on, so if you stress the bone marrow with an infection or things like that, more platelets might go into the blood. So that's, I'd say, kind of normal physiology of the body from that perspective. White cells are the same. If someone runs up and down stairs, their neutrophils will go up. So you could have a neutrophil of 1, and we used to do. I do this sometimes, not for cancer patients, but there are people who we see for just neutropenia, low neutrophils as a consult, and some people are just, for some reason, their neutrophils are sticking to their blood vessels, and so when you test it, you can't see it. So I tell them to go up and down like 4 flights of stairs, and they get tested again, and their neutrophils have gone up by 2 or 3 points. So again, that's kind of normal body physiology from that perspective. And then on top of it, if you are on chemotherapy, for example, even from day to day, in terms of how the bone marrow is recovering things like that, the blood counts will go up and down, just depending on where one is in the cycle and what treatment they've had and things like that. So that's a very good question. The question was around, can you change your type of myeloma and the cytogenetics of your myeloma? So the type, so our myeloma is based on our body makes different immunoglobulins normally to fight infection. So we have IgG, IgA, IgM, and then there's 2 different types of that, kappa and lambda. So the type you have, meaning what's the immunoglobulin that your myeloma makes, like IgG or IgA, that doesn't change. So that always stays the same. The cytogenetics, which means mutations that your cancer has that renders it more resistant to chemotherapy, which are when we talk about high risk, are things like 17p deletion, translocation 414, those you can acquire. So as treatment goes on, so someone might not have a 17p deletion at the beginning, and then when they relapse, they've acquired. So their myeloma cells have mutated more and become more aggressive. So you can acquire a 17p deletion, at which point it would be harder to treat. Absolutely. So, hasn't been traditionally, because we weren't really doing that much different, we weren't doing anything differently about that. We don't know that we should treat those patients differently, although now there's many more treatments. Prognostically, it's useful information to give patients if we think things are more aggressive. So we don't routinely necessarily repeat, because you have to do that on a bone marrow test to retest it. So we don't necessarily repeat bone marrows at relapse for patients, but we are involved now in studies to molecularly understand myeloma. So we're doing a bit more of that because we're trying to understand better all the genetic changes that happen as the disease progresses. Just to recap this slide, again, looking at the combination of adding some of the novel drugs to Revlimid and dexamethasone and some of the results we're getting. And I just wanted to show you a couple of slides updating a couple of those combinations. This is a slide of the carfilzomib, Revlimid, and dexamethasone versus Revlimid and dexamethasone study. And all we've had in the past was that there was a significant improvement in progression-free survival and maybe a trend towards overall survival, so meaning people live longer getting one combination versus the other, which is sort of the holy grail in clinical trials in general in cancer, because the disease staying in remission for longer or response rates are what we call surrogate, sorry, this must be on a timer, surrogate endpoints. And they matter more for some diseases than others. But if we can show that a therapy of combination of drugs or single drugs makes people live longer than the other treatment, there's no arguing with that, and that's something that's a very meaningful endpoint. So in this, in the ASPIRE trial, which is the KRD versus RD, at ASH this year, they're finally able to show that the survival rates were different between the two arms, meaning, and that just had to do with the amount of follow-up. So to show survival in cancer these days, sometimes depending on what the drugs are, you just need to wait, you just have to wait long enough, especially if it's a disease that's slower growing or indolent, where it takes a long time to show some of those differences. So there again, you see that the curves are separating quite nicely between the two, and there seems to be about an 8-month median improvement in survival when adding carfilzomib to Revlimid and dexamethasone, which I think is a very meaningful amount of time in this disease. The other exciting combination that I talked about was the daratumumab, Revlimid, and dexamethasone combination comparing to RD. And this is just PFS differences. And so this is, again, this is not necessarily newer data, but to compare to what we saw with KRD, because I think those are going to be the two combinations that likely will be approved in Ontario as options. But they won't be combinations really that we won't be able to give them both in a patient even sequentially, because once you've used one, probably the utility of Revlimid, and one progresses on the triplet, the utility of using still Revlimid won't really be there. So we'll have to choose kind of probably in second line for patients whether we want to do KRD or DARA-RD. once we have those available. So we can see with this trial, which was called the Pollux study, there was quite a significant difference in progression-free survival between the two arms. So if you calculate relative risk, there was about a 60% reduction in risk of progression or death with the 3 drugs. There was no survival difference yet, but the follow-up for this trial is much shorter, so probably we just need to wait longer to see that difference. The further down the more heavily treated options are triplets that can be with pomalidomide and dexamethasone. So in Ontario, we have PomDex approved for patients when they've failed bortezomib and Revlimid. We can see that when we had nothing else, this was shown compared to just Dex alone, which is really not a very good treatment option, but kind of what was used as the comparator arm, that there was a progression-free survival advantage of a few months, and so on average is about 5 months for PomDex. So although that's available, most of us don't really feel comfortable just giving, or don't like just giving PomDex if we're looking at a relapse after Revlimid. So people have again been looking at triplets, as per the question before. We often add cyclophosphamide to PomDex because it's an easy thing to do in terms of what's available. But people have tested, or there's been, so that's the palmcycloprednisone. Same kind of concept. You can see the PFS was certainly longer than the PomDex alone. There's been testing of adding bortezomib to PomDex, especially if it's been a while since, if one just had it pre-transplant, for example. There's a combination, so these are not randomized controlled trials. These are just single arm where people, a number of patients just got this combination and they looked at what's the response rate and how long people stayed in remission for. So PomDex and carfilzomib, I think these were patients, so now we're getting into patients that are quite heavily treated. It was about 7 months PFS, and then there was a study at ASH just looking at what happens to patients when they add daratumumab to PomDex. So it's safe, and it seems to, people can give it, and the response rate was about 66%, and there was a median PFS of about 10 months. So it's certainly a promising combination, and we may see some randomized trials coming of comparing the triplet to a doublet. For example, if trying to get this approved as a regimen, it usually sort of goes for FDA or US approval, but something maybe for us as well. So those are combinations of the drugs that we've had, even through compassionate use, reasonable access to recently for our patients. So we're able to, even though carfilzomib and daratumumab are not funded in Ontario through insurance plans or compassionately through the company, we are able to get it for a good amount of patients. So those are kind of well-established drugs. We know the toxicities and the efficacy we might expect. What's the exciting part that's coming? So I just have a few slides to update you on that. And really the new therapies that have made a splash are using what's called BCMA as a target. So BCMA, or B-cell maturation antigen, is a, I don't have a pointer, but these little proteins on the overexpressed on malignant plasma cells, so it's a target on normal B cells, but also particularly on plasma cells. So people have looked at researching drugs against this target, or using this target to enhance cancer death, or plasma cell cancer death. So this particular drug, GSK 2857916, is a drug that actually Dr. Suzanne Trudell has been heavily involved in developing, and she presented at ASH this data on this drug, and it was very, very well received. Is a drug that actually conjugates or puts together an antibody to this target, and this concept is called an antibody drug conjugate. So what it's doing is it's taking an antibody and adding to it a toxic molecule. So the drug goes and attaches to the target, and then gets inside this toxic molecule into the cell. So it kind of uses it almost like a Trojan horse kind of idea to then send this toxin inside the cell, and that kills and leads to cell death. So it's been a very exciting concept in other cancers and other lymphomas and other things we've been doing, and that's the concept behind this drug, and it leads to cell death through a number of different mechanisms. So the study that she's been involved with so far has been a phase 1 trial, but it's, or phase 1 to 2, and it's now going forward for development in combinations. I think we're going to have a trial of this drug combined with pomalidomide and dexamethasone. It's very well tolerated, not very many toxicities. And these were patients that were heavily pretreated. You can see at the bottom in more than 5 lines of therapy. And this is what's called a waterfall plot. So all the bars that are below the 0 line are people that had a response. So the overall response rate in these patients was about 60%, which is really quite remarkable, and it's very active for this population. It's very well tolerated, it's convenient, but it is given IV every 3 weeks. The other therapy you may have heard about, and I just wanted to spend a couple of slides on, it's what's called CAR T therapy. And this probably will, this concept is revolutionizing treatment in hematologic malignancies and in cancers in general, something called cell therapy. And the idea behind this is that CARs, or chimeric antigen receptors, are proteins that recognize cancer markers. People have been trying to understand what is it that our body is programmed to fight foreign things. So the immune system should fight cancer. So if you have something that's growing and it's aberrant in your body, our immune system should be able to recognize that and try to kill it. So why does that not happen better? And that's because cancer is very smart and has learned, or sort of mutates as it produces, to learn to evade the immune system. So people have been looking at therapies to try to wake up the immune system and to enhance it so that it fights off the cancer. So these proteins recognize cancer markers, so there are genes that can be inserted into T cell DNA by a virus to express. So T cells are our body's way of fighting things, including cancer, infections, etc. So the idea is, can we enhance a person's own T cells to make them fight cancer, fight the myeloma, for example. So what happens is, this is a reasonably invasive and toxic procedure, so this will definitely not be for everyone, and there will be many factors that will go into whether someone can tolerate this and is eligible for this therapy. But the idea is to remove blood from the patient. So a myeloma patient would get their T cells removed, and there's ways we can do that. It's the same as we collect stem cells for stem cell transplant. It's the same process, but instead of collecting stem cells, we're collecting T cells. And they go to a lab where these genes get inserted into the T cells to produce these receptors, and then they're grown to millions of cells. And then these CAR T cells are infused back into the patient, with the idea being that now these T cells are super pumped to recognize the cancer cell and then fight it off. So they're going to bind to cancer cells and kill them. So different cancers have different receptors that will be targeted. In myeloma, it's BCMA, because we know that it's a very good target that's on all plasma cells. So the preliminary data we have in myeloma on this is a construct called BB2121, which is an anti-BCMA CAR T cell therapy. And the data that has been presented is on 21 patients that received this. It is there are many toxicities that go with this. It's akin to having a stem cell transplant, even an allogeneic stem cell transplant, in terms of monitoring. People will, as a start, will have to come in as inpatients. There's been very unique toxicities, which is something called cytokine release syndrome, because these T cells are very inflammatory and very active. So when you put them back in the patient, they create what's called essentially like a cytokine storm, so like just massive inflammation. So some of that toxicity has come from that. So people have on other trials with other targets, it's the kind of treatment that lands people in the intensive care unit, even in coma type situations, but we've learned how to manage that and how to treat that. And the exciting thing about the BCMA construct or the myeloma construct, it seems that that toxicity is not, we're not seeing it in the same way. So it must be that the way the T cells are targeting or what the target is just doesn't produce the same kind of toxicity. So when we look at grade 3 or higher, which are when people are really sick from a side effect, it was only about 10% of that cytokine release syndrome, which is actually quite good compared to what we've seen in other cancers, and neurotoxicity was 0. So it's actually very exciting, and we think this is going to be really not as toxic as we would have thought. We can see that the patients on these trials, this was the chart on the left is just to show that they've been people who had been exposed to pretty much any of the treatments we have, so bortezomib, carfilzomib, Len-Pom, and daratumumab, and combinations of all. So these are very heavily pretreated refractory patients. So I'll just have you focus on the left. This is showing that in these heavily pretreated patients, so the yellow bar is a partial response, meaning that the protein came down by about 50%. A blue line is VGPR, which is a 90% reduction in protein, or a complete remission is yellow. And we can see that most of the patients had some sort of response with this treatment. It seemed to be dependent on what's on the left is the millions of cells that were grown and given back. So it does seem that the lower part was where they only got about 50 million cells, and those patients didn't do so well. So you do need some critical mass of cells to grow in the patient to get the responses. But this is very, very exciting for this disease. The overall response rate was about 94%, with 56% of patients getting complete remissions, and 9 out of 10 patients who had MRD checked were negative. So that's remarkable for, again, very heavily pretreated patients. And it also seems that the responses can deepen over time. So when they first presented about 15 patients in May of 2017, they had about 27% CR. When they added up 3 more patients but had longer follow-up for some of the patients, the number of CRs really increased as well. So you might not get all the response up front. It could take time as the cells, we believe you have to have the cells, the T cells, so these T cells that are fighting cancer essentially persist in the blood and in the body, and they continue to work through time in a disease like myeloma, which is an indolent process. So there may be questions about that, so we can have those at the end. I just have a couple more slides on one other study that looked at, so completely switching gear. It's so not talking about myeloma drug treatments targeting myeloma, but one other interesting study that got reported is whether we should give everybody antibiotic prophylaxis. And this was a study that randomized patients to getting levofloxacin, which is an antibiotic, versus nothing for about 3 months while starting on therapy, some form of myeloma therapy. And that's because it's been identified that we know our myeloma patients get infections, and lots of them, and most of them seem to occur in the first few months of diagnosis. And it appeared the endpoint was the number of febrile episodes or death. And giving this levofloxacin antibiotic reduced the number of, so that's the red line on the bottom, so there was less febrile episodes or death with giving an antibiotic versus not. It's not our standard to use this antibiotic routinely, let's say when people start on Cybor-D or VMP or RD, but it seems to be something to consider, and it has an additive effect to other drugs we use like Septra, which we do sometimes use in our patients. So I've shown you lots of data. We do lots of trials and such activities at Princess Margaret. So what are we studying presently? There's a big focus on molecular profiling of the myeloma cells from the bone marrow and blood. You've heard me talk about, and there's been questions about acquiring mutations and things like that. We're trying to understand how this works. And Dr. Trudell and Dr. Tiedemann, who work with us, do a lot of work in this area. We have a number of studies of different combinations and sequencing of various therapies, trying to understand. So this is a way to access some of these drugs and combinations that maybe won't even be available through funding. So including pomalidomide, carfilzomib, daratumumab. There's a drug we've been working with called selinexor. We do have some drugs in early phase of development specifically targeting 17p mutations or T414 mutations. The anti-BCMA antibody conjugate combination studies, the drug I mentioned to you that Dr. Trudell is studying, are coming. CAR T therapy is coming. We're in the process of opening that study, so that will be available to select patients. It will be there are many logistics that go into that, but we definitely will consider appropriate patients for that. We hope to have that open in the next, I'm going to say optimistically, 2 to 3 months. There are other early phase drugs being tested, and we're not talking about amyloidosis today, but we also have studies for patients with that sometimes associated disease of myeloma. I can speak to it. There we go. So what are some take-home messages? For frontline treatment, for transplant ineligible patients, there could be a potential new standard with the addition of DARA to VMP. It's hard to know if patients who are elderly or frail, where it means coming back and forth to the hospital a fair bit, would use it, and we won't have any direct comparisons to Revlimid and dexamethasone. For frontline transplant eligible patients, it does seem that tandem transplants are still valuable, especially in high-risk disease. Relapse disease, we do see daratumumab in lots of combinations everywhere, but we need some more efficacy data, and things like cost and convenience will be an issue or things to consider because it is intravenous with long infusion times at the beginning. And it really seems that the new therapies that are making a splash are these BCMA targeted immunotherapies, whether it's the drug antibody conjugate drug or CAR T therapy, and probably we would consider that the antibiotic prophylaxis I've showed you should be added to our regimens for newly diagnosed patients starting therapy. And I think this has been shown before, but we are always very thankful for everyone that participates in trials, because that's the only way to really move all this forward. So those are all the slides I have. This is our team at Princess Margaret, and we particularly value referrals for very complex, difficult patients in terms of their disease management and clinical trials. So I'll stop there, and then I'm happy to take questions. So the comment and question is around adjunctive I'm going to say therapies to drug therapies for myeloma, and I think those are really, really important. I can't say that probably we're not standardly integrating them into our care. We depend on patients' initiatives in terms of finding these therapies out, although there are some studies ongoing in some populations of things like, so we do have a supportive care psychosocial oncology department who's very interested in some of these questions, and I know they have a couple of studies, one related to a Tai Chi intervention for some cancer patients, definitely things like mindfulness and those kind of interventions are important. I think people are recognizing that those are a key piece. I would agree with you that, you know, multiple myeloma is a little bit of a marathon rather than a sprint, I think, for most patients. And the first part of treatment is a lengthy, intensive process, whether you're transplant eligible or not. And then there may be some periods off treatment, and some people have longer periods of treatment, of which hopefully they get back to normal life. Some people are on and off treatments with some side effects at all times. So finding ways to cope with that, I guess, and manage that, I think, are really important. And we hope that we have at least the information out there sort of available to give to patients, and probably we could do a better job of recommending or knowing what things are better than others. So certainly if people have experiences with treatments that helps with neuropathy, for example, in terms of yoga or mindfulness, I think that's a useful information for us to pass along to others. So that's a very good question. The question was around treatment and trials for smoldering myeloma. I didn't spend too much time talking about that today. You're right, we did have a daratumumab versus placebo trial for smoldering myeloma, and that has not yet been reported out. So we don't have any data or information on that trial specifically. So that will be interesting when that comes out. There was a study at ASH this year, which for the interest of time, I didn't put in, which was a much more aggressive approach from the Spanish group for smoldering myeloma, where patients got the best chemotherapy you can think of, 2 transplants, some more best chemotherapy, and then a bunch of maintenance to say, almost with a, can we cure it before it becomes symptomatic. The problem is it's not a randomized trial, so we don't know. So yes, everybody responded to the therapy, but it was a lot of therapy, so it makes sense that they had people had responses. Would that kind of approach make people live longer or cure patients? So they're going to follow things like MRD, for example, and say, at 5 years, 10 years, are people still in MRD negativity? Did we achieve something different? That's probably the most data we have so far, but we look forward to the idea behind that trial was, maybe it's not as acceptable to give chemotherapy for patients we don't necessarily think need treatment yet, but daratumumab is, people find the word immunotherapy sometimes a little bit more palatable than chemotherapy, less side effects. Maybe you're modulating the immune system again, some of the things we've talked about in terms of changing how the immune system sees the cancer, where if you give Dara, you can now kind of your immune system learns to control the cancer for a long period of time, was the rationale behind it. We'll have to see some of those results, but none of them have been reported yet. Right, exactly. So the question is around, there are some attempts with more traditional vaccination approach, like vaccines against measles, to induce an immune system response against the cancer. And I would say the concept is the same, whether it's a direct, people have been in cancer have been researching vaccines for a long period of time, and some kind of worked and some didn't. So the concept behind these therapies is kind of the same, but much more enhanced, and particularly the process of we're actually taking out the immune system, manipulating it, and putting it back into patients. So it's a much more, enhanced approach from that perspective. Yeah, I'm not sure. I must admit, we haven't heard much more, and don't know if that kind of worked, the measles vaccine, after those couple patients progressed any further. I don't have more information about that. So that's a good question. The question was around subcutaneous daratumumab, and again, in the interest of time, I didn't show you, there was some phase 1-2 data at ASH about a more convenient way of giving daratumumab, which is under the skin, and it seems to be sort of just as efficacious and well tolerated. And I'm not sure if it's open, I think it is open actually. I believe our trial is open of comparing subcutaneous Dara to intravenous daratumumab, so we do have that as a trial. So the question is around the cause of multiple myeloma, and I guess the short answer is no. What I often say is, I'm not sure that we're going to have a particular etiology to ever blame. Probably in some of what happens with blood cancer specifically is that our immune system is just very active through our lifetime. It does lots of things, it multiplies a lot, and when our cells multiply, they make mistakes. And our body has ways of fixing those mistakes. They have mechanisms to do that, but sometimes they miss those mistakes. Most of the time the mistakes are in areas where it doesn't matter, but if that mistake happens to be in a gene that's critical for keeping cells alive, then the cancer multiplies. So that's a good question. So the question is around whether there are studies linking or looking at stress and multiple myeloma. Not that I'm aware of that have shown anything any linkage, but I can't say that I've looked recently if there's anything people have reported on. Those are very difficult studies to do because or to even try to capture is because how do you capture stress in retrospect, and how do you homogenize what stress means to different people? I mean, we have, of course, questionnaires and scales prospectively to test people's anxiety and things like that, but if we're talking about trying to link, because we can only look back once. If someone has myeloma, you might say, okay, did they have stress before in their lifetime, and how do you measure that? So it would be very hard to make that kind of linkage, I think. Right, so the question is around how does how do the mutations happen to lead to cancer? So it's similarly linked to the question that was asked before. There are some cancers out there where there's a clear linkage, like smoking and lung cancer, for example. In myeloma, I don't believe that we've identified environmental factors that cause that. And again, our body mutates and makes mistakes in genes and makes mutations all the time. It's part of normal body physiology and regeneration, and we have mechanisms to repair those mistakes. But sometimes it doesn't. Sometimes
so the physiology is not going to fix it for you, just alone from that.
Sometimes I think it's just chance and bad luck where that mutation happened, and that's what leads to the cancer. Bad luck is a funny way to say it, but it's chance. It happened in a bad spot that then leads to, because we have genes in our bodies. Our body has a way of balancing, making too many cells and making too few cells. So because we have to grow cells all the time, but we don't want to make too many. So there's all kinds of proteins, mechanisms, pathways that keep that check in balance. So if a mutation happens in one of those, in a key, so 17p or p53 is like the key example. That's a protein that's just very involved in the cells dying and cells growing in the body. So if one has a mutation in that gene, pretty much in any cancer, it leads to a worse cancer. Most cancers are not just one mutation. There's other ones, even if we're not capturing them. There's lots of things that get mutated, or not lots, but there's a number of different ones. So it's a very complex process as to what leads to cells just not knowing that they have to die.
So there's no study or research under that?
There's lots of studies and research going into that. We just don't yet have the answers. Correct. So the question is around whether there are tests that can definitively say that there's amyloidosis, and the answer is yes. The caveat to that is that has to be on a tissue that has amyloid in it. So there's no, well, there.
Do you know what tissue that is?
Based on imaging, so looking for organ involvement. So if we suspect someone might have it, we do things like echocardiograms, ultrasounds to see if there's thickening of something that should be biopsied. Dr. Tiedemann, for example, my colleague, he is collecting, so if you come to our center and someone tells you you might have amyloid, ask about his study, because he's actually collecting blood from patients who might have suspicion for amyloidosis to see if you can detect it in the blood, if you can detect some of these amyloid fibrils in the blood. So that's ongoing work. And that's what a lot of the work is going towards now as well. In myeloma, Dr. Trudell does a lot of work in this, which identifies that the myeloma cells can shed some DNA into the blood. So there's ways to actually test for mutations and do lots of very sophisticated things. So rather than saying you have to do bone marrows or you have to do biopsies of organs, can we pick up very small amounts of these cancers or this amyloid in the blood and test it on that? So that work is ongoing. But if we, let's say we do a bone marrow or a liver biopsy and we identify amyloid, so it looks just like pink tissue under the microscope, we have a test to determine exactly that it is and what type it is. But it's still a bit more invasive than blood, you're right.